good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to a very special episode of Open Mics with Dr. Stites and our monthly edition of Show Me the Science. We have now entered the 5th year of COVID-19. And in a few moments, we'll show you some data proving COVID activity in year 5 is looking a whole lot better than years 1 through 4. Today is also the last day for the foreseeable future that we're going to share the hospital systems or the health system's COVID count. We're going to explain why we're making that change. And by the way, it's good news. And while we reflect on the last 4 years, we're also going to be keeping an eye on the future. I'm sitting here with Hawkeye, also known as Doc Hawk, also known as Dr. Dana Hawkinson. By the way, nobody calls him that anymore. This show has indoctrinated officially. He is now Doc Hawk, the Health System's Medical Director of Infection Prevention and Control, good friend of this program and to me. And I'm thrilled to welcome back Dr. Gregory Poland. Dr. Poland is a vaccine expert and the director of the Vaccine Research Group at Mayo Clinic. Dr. Poland, how are you?
I'm doing well, thank you. We made it through 4 years.
Yeah, it's awesome. And you know, Dr. Poland, I think you now have a faculty appointment here at the University of Kansas. You're on so much, I think we ought to just give it.
That would be a privilege.
It would be a privilege to us. Before we talk about COVID, let's do our morning rounds, though. Transplant surgeon and associate chief medical officer and the guy who tried to fill in for me these last couple of weeks, I'm sure he couldn't really do it. But anyway, it's not as easy as it looks, is it, Sean Coomer?
Man, it was a great, I got invited back. I didn't screw up that bad. I had a lot of fun, kind of keeping things warm, the seat warm for you, Steve.
I hear you've done a great job. I had to go back and watch those video clips. The good news is you and I have about the same quantity of hair, and so people probably already can tell the difference if they have glasses. All right, I'm told that while I was gone, while you were gone, there were some transplant numbers that got shared. As it turns out, the transplant program here at the health system set a new record. Talk to us about that.
Yeah, it's been pretty exciting. My partner's been really busy here recently. April was extremely busy with 45 total organ transplants. That's an incredible number, 37 of which were kidneys, and that's a record for us in a single month. There were also 5 livers and 3 heart transplants, and I think last Wednesday when we reported there were 91 transplants, and the team did 2 more livers and about 7 or 8 more kidneys over the weekend. So we're over 100 in just 4 months, pretty incredible numbers. So our transplant team is actually celebrating today with Topsy's popcorn, 72 gallons of it apparently.
Holy cow.
Yeah, so they'll have fun. It's been.
Are we going to have to do a transplant somebody after that? Because
most likely. I don't know if we'll be doing stomach transplants yet, but clearly it's going to. But nonetheless, this is the serious part of this is that these numbers are incredible and there's a lot of need out there. The transplant waiting list is 10 times the amount we actually transplanted just in the past month or so. So please say yes to organ donation. Go register to donate. Go to DMV, donatelife.net. And if you want to be a living donor, please don't hesitate to contact any of your local transplant centers. So thanks again for having me. And Steve, let me fill in for you for a couple
you do a great job. Good enough that I got to take some more time off. No, you did a great job. Thank you. And congratulations to you and the transplant team. As you all know, transplant's near and dear to my heart. Someday, hopefully, we'll be doing some lung transplants. But in the meantime, we work closely with Barnes around that. But we are really so supportive of the liver program, the kidney program, clearly the heart program, the bone marrow transplant program, pancreatic transplant program. Those are really, really important things. And I can't tell you, my brother had a lung transplant, and I can't tell you what a difference that can make in somebody's life and how hard it is to go through it. Having that team here locally to support you, especially one as outstanding you guys, where all the programs are in the top decile of the country in terms of mortality and things like that, and performance. You guys are just awesome, and we really appreciate you, and I know our patients appreciate you every day, so thank you.
No, thank you.
You and your team. You and all the team.
Thanks.
All right, thanks, brother. All right, now, let's going to talk a little bit now about what happened. Now, this program was born out of necessity. In March 2020, we called it the Morning Media Update. And we engaged reporters directly because we felt they were sometimes a little too focused on the wrong questions. Instead of focusing on how many ventilators we had, we wanted to focus on flattening the curve and avoiding the awful scenes we were catching in New York, Milan, and other places in Italy and elsewhere. We're going to take a couple of minutes now to reflect on how this program started. We're going to start with a video with a small warning. This could trigger some pretty significant emotions from a pretty scary period.
So we're talking about the coronavirus. It's killed 17 people in China. What are we knowing and learning about it?
This looks to be possibly more dangerous, as we do have so many people that are now being infected.
Tonight in Washington State, the outbreak turning deadlier.
I think it's always good to hope for the best, but prepare for the worst.
Our purpose of this press conference today is to answer our questions about protocols for care and for public safety. What I can tell you is that I only know of one patient thus far that's been positive in the state of Kansas.
This is a very new infection. We still don't know all of the infection dynamics.
Beautiful day in the Rose Garden. Appreciate everybody being here. Today I am officially declaring a national emergency.
Certainly in the KC metro area, we believe there is community spread. Self-quarantine, self-isolate, do social distancing, do not meet in large groups.
We're at the beginning of the curve. We haven't even started having that many positive patients yet. If you're sick, stay home.
Why is it so important people follow these rules and stay at home if they're at home?
Because there are so many people that can be infected, those numbers can escalate, and that can quickly overwhelm our health system.
Over the weekend, we went to stay at home.
How common is asymptomatic or pre-symptomatic spread?
Like up to 30 to 40% of infections may have happened because somebody is asymptomatic.
This is Steve Stites, broadcasting live from the Dolph Simons Family Studio here at the University of Kansas Health System.
Currently, we have 36 patients.
Wear a mask. Wash your hands.
We remember that the mask needs to be above the nose and below the chin.
You are strong. Hello, Doc.
Hi, how are you?
I understand they call you Hawkeye, huh?
Yes.
Is that a MASH reference?
It is. I think there is cause to be optimistic. You know, right now there are no approved drugs, but we have the best minds in the world working towards that.
And then ensuring that you're doing your fingernails and your palms as well.
But what about giving out candy? How can we do that safely?
I think just trying to stay 6 feet away is it. Today was a historic vote. Just less than an hour ago, as committee members decided the best way to allocate the first COVID-19 vaccine to gain FDA emergency use authorization.
We wanted to talk a little bit about the Omicron variant, just because we know it's not in Kansas yet, but it has hit other parts of the U.S. Do you see it coming here soon?
You know, I have to believe that it will be here soon if it isn't already.
Our beds are at capacity, staffing is at capacity.
I had one day where I had 3 people die before 9 a.m.
You know, lots of people they're tired of it, they're sick of hearing about it, right? Nobody's more tired of it than we are, but we're still here and we're doing it every day. I hope and I wish that people would trust us for this and listen to what we're saying and asking people to do.
Thankfully, the Kansas City Metro did not look like New York City or other big cities. Doc Hawk, what's it like reflecting on our own work on this program?
I mean, it was a lot of work, and I agree with you. You know, some of those things may be triggering for many reasons for many people. Certainly, I think we were always thankful we got to continue to work, and I think we did take it as our mission to provide that accurate information to the general public. And that really kept me going. I think that kept us going during all of that time, especially those first few months for sure.
You know, I think I used to say you can't be a flapjacker. You can't flap your arms and jack with the truth.
Yeah.
And that was one of the biggest things we tried to do, is just to tell the truth and be honest about it and do it in a calm and reasonable manner. And most of all, to offer some hope, because there was always hope.
Yeah, absolutely. And I think there was early on, and then we heard, even a few months later, we heard the early hope of the vaccines that were being trialed, and then they were rolled out later that year. So I think the hope was there. We needed to continue to be transparent. We didn't always have all the answers, but that's what science and medicine is about. We don't always have the answers. A lot of times the answers was, we'll see, we'll have to see what it's like in 2 weeks. But we kept continuing that and kept trying to be transparent and present that message.
And I think we kept saying, you know, you can play defense, but once we had the vaccinations, we were Patrick Mahomes in the offense with such an incredible efficacy, unlike anything ever seen before in the world of vaccination. We're going to talk to Dr. Pullen about that in just a moment. But today, we're going to give something that I hope is really true, and that is the final COVID count. Now, the count isn't true, but that word final.
Right. Yeah, I mean, it feels good to say that, and we've been hoping for those low numbers of hospitalized patients. We know COVID still does affect certain populations. They still have high risk for hospitalization, severe disease. Right now in the hospital, we have 4 active inpatients. Very good. Just a couple weeks ago, we were in those double digits, but now for the last couple weeks, been in those single digits.
Yeah, it's such a great feeling to be there, and knowing that we are in such a better place. And on a national level, we know that hospitalization data and wastewater data show that COVID activity is indeed very, very low. If you can see this wastewater activity, it's really dropped off significantly, and that's often been a harbinger. When that rose, then we also knew that the other numbers in the population may rise.
Yeah, absolutely. You know, I think this was a good bellwether that we use to look at circulation in the community. But just as you said, we could predict then, will there be more hospitalizations and more severe illness, because we saw that curve rising.
And we see the new COVID vaccinations week by week at a really remarkable low now for the first time in years. So Dr. Pullen, should we still call it? First of all, welcome back to our program. God, it's been a pleasure getting to know you. It has been the best to have you here, and I can't tell you how much that's meant to us and to our public.
I love working with you guys, and I think your show has been fantastic. And as you know, it's not just viewed locally, it's viewed nationally and internationally. So congratulations.
Yeah, thank you. So should we call this a pandemic now, or what's the word for it?
You know, we haven't really invented a word for something that changes so rapidly like this. I think it's fair to say, though, that we are truly moving into the endemic phase of this. And what that basically means is that we're going to have COVID with us forever. Our great-great-grandchildren will be getting COVID vaccines, unfortunately. What we can't predict, and has a certain likelihood associated with it, is that this hypermutable virus will learn how to evade our infection-induced and our vaccine-induced immunity and cause a new rise in infectious cases and in deaths. That's an entirely plausible scenario. Will it happen? We don't know. We cannot predict what the virus will do and what the mutations will be.
So as of today, hospitals are no longer required to collect and share COVID data with CMS, the Center for Medicaid and Medicare Services, which means COVID surveillance will have to rely on the old CDC system, RespNet. How hard does that make it to track COVID? Talk to us a little bit about that.
Yeah, that you know, I understand why they're decreasing it. I mean, a lot of resources have gone into this, and you can't just keep pouring resources into everything. You have to make judgments, and this is in part, I think, a reasonable judgment. The problem with ResNet, the problem with wastewater, is you're always behind the curve with those. You don't know what variants, you don't know how sick people are from that. So, you know, to me, as a vaccinologist, the more data, the better. You're right that we are down. People see those curves and they think, oh, no big deal. But last week, 5,600 Americans got sick enough with COVID they had to be hospitalized, and 230 of them died. So, that's still a significant burden of disease. It's just that relative to where we've been. Remember, with Omicron in early 2022, we were looking at about 150,000 hospitalizations a week and about 25,000 deaths a week. I mean, it's almost hard to imagine. Looking at that video made me, kind of relive that. We were working so fast and hard that it seems an absolute blur. But, we're now facing new variants, which maybe we'll talk about.
Yeah, I think, it is amazing to be I know you obviously love research and do this really remarkable work. I also understand you're a bit of a lover of history. Is the cycle length for a pandemic, I just think about influenza, is the cycle length for a pandemic, is it just going to be 3 or 4 years? Is that just what we should always expect? I mean, I don't know. Talk to me about that relationship between influenza and COVID, and how much time does it take for it to kind of work its way through a little bit?
Yeah, I wish I had a clear answer to that, Steve. The problem is it's so dependent on the virus and the things that are happening in the population. Let me give you an example. B. Yamagata, one of the 4 strains that's in the influenza vaccine, has disappeared. And it disappeared during the time we were mostly all wearing masks and social distancing. That's the answer to the argument of, well, masks don't work. Well, they certainly do. We had almost no RSV. We had almost no influenza. And those are really harbinger, respiratory viruses. It looks like the B. Victoria strain is going to leave us. On the other side of the coin, though, the 1918 pandemic virus that circulated in its kind of descendant form continues to circulate today and is in the vaccine that we get when we get influenza vaccine. So over 100 years later, we're still immunizing against that family of virus.
And do you think that we put ourselves at risk because we wore masks, and therefore when we took them off, RSV was more terrible and influenza was more terrible, even though, can I just say it out loud, neither were really that much more terrible? So, I mean...
Yeah, and I think when people say they were more terrible, I think predominantly what strikes them is that there was a surge in infections. That makes sense. RSV is something you get repeatedly infected with. Influenza is something you repeatedly get infected with. So, you haven't really boosted natural immunity during those couple of years where we were pretty good at social distancing and at wearing a mask. Then you stop those. And of course, there's a surge. There was, you probably saw this article just recently that came out when I think it was 6 Massachusetts hospitals, when they stopped masking and testing their hospitalized patients, they had a surge in infections again. So some of that is to be expected, but the dynamic changes because unlike 2 or 3 years ago, where there was not a high level of population immunity, now we have in virtually all of us combinations of immunity, infection-induced immunity, vaccine and vaccine-boosted immunity, and that makes for a very different dynamic that the virus has to operate in.
So we're going to probably still need some new vaccines. This week, the World Health Organization said the new COVID vaccines coming this fall should use a monovalent JN1 lineage. But if we look at the variant snapshot from CDC, JN.1 used to be dominant, but not so much anymore. On the left, going back to January of 2024, lots of purple, which is the JN1. But more recently, other variants like KP2, JN1.7 are gaining ground. Dr. Paul, how difficult is it to navigate all these things and keep up?
Yeah, that's a great question. If we can just leave that graph up for a moment. The issue, as you can see, is that this changes very quickly, and it changes faster than the attention span of the American public. And that's one important point. The second thing is when you look at JN1, 1.7, 1.13, KP2, KQ1, everything that's composing those bars there, they are all JN1 family variants. So even though almost certainly it will not be JN1 that's circulating this fall. It will very likely be a JN1 variant. And fortunately, as we saw with the most recent monovalent XBB 1.5 variant vaccine, there's enough cross protection to protect people from severe disease. These vaccines, and again, let me emphasize this as a vaccinologist, they work well in preventing infection for weeks to months. They work spectacularly well for very long periods of time in preventing severe disease, death, hospitalization, having to go on mechanical ventilation. And that's the reason for the vaccines. I hear so many people say, whether it's flu or COVID, I got the vaccine and I got sick anyway. And you just want to kind of yell, but you didn't get hospitalized and you didn't die. And that's why we give these vaccines.
You're alive. Yeah, so Hawkeye, these variants, kind of all in the family, huh?
Yeah, and I'd like to hear Dr. Poland's comments, but I think what we have said as well is, again, understanding these vaccines will help protect you against hospitalization, severe disease. But what we want to talk about when we talk about the variants is that a lot of what the news is talking about when they talk about the variants is the spike mutations. And the spike is what our mRNA vaccines are made to. However, what we have also seen, really, besides Delta, which was a little bit different, maybe caused a little bit more severe disease, all of these variants have really caused the same spectrum of disease and severity and propensity to cause that severity. So we haven't seen a big fundamental change in the virus just yet, and Dr. Poland mentioned that earlier. Could it happen? Certainly, we always need to be watching out for. But we also have the immunity, not from the antibodies that we hear about in the news when you talk about we don't have immunity to it. That is mostly what they're talking about. But we have still our T cells. And our T cell immunity has really stayed about 80% conserved between all of the variants. And that is really what we get and what gives us protection from that severe disease overall. And so thankfully, we do have that T cell immunity as well.
So guys, I want to just have a little fun here for a minute. What's up with the variants that are nicknamed Flirt, as in flirtatious? I mean, really, when I think about COVID, the word flirtatious isn't the first thing that comes to my mind. Who named that, Dr. Poland? Did you name that?
Well, yeah, it's a funny kind of naming convention that we use as a shorthand way. The FL refers to a spike mutation at the position 456, and the AT or RT refers to a mutation at position 346. So they sort of added the I in between and made it Flirt, just like we have slip variants and other things. So Hawkeye's exactly right. These are just mutations on this S protein or spike protein, and this is a way to identify them.
The future of vaccines, and we've learned so much. And first of all, you guys have both said, I'm just going to say it out loud, mRNA vaccines, oh my gosh, are they so safe. Yeah. We're going to come back to that topic in a moment. But what about some of the future vaccines? How far away from oral, nasal spray vaccines, other kinds of innovation and development for this? What's coming at us, Dr. Poland?
Well, Steve, I'm really excited about this. The mRNA was a new platform. We had not used this before. And so we've seen the value of that. What is happening now are self-amplifying mRNA vaccines. One's already approved in Japan. So instead of getting a dose of 30 with the mRNA vaccines, you're getting a dose of 3 to 5 micrograms of this. So much less reactivity and yet good immune protection. That will lead into a whole series of candidates that are being tested right now, which, as you pointed out, induce immunity at the portal of entry, mucosal immunity in the mouth and in the nose. Those are coming. Work is going on. It's strong work. We will have those, I hope, within the next year or so.
So that's really remarkable to think about that, and all that science, I'm sure had to be accelerated during the pandemic because people work so hard on the research. Is it broadly applicable to other diseases?
Yes, there's no reason that platform cannot be used for other diseases. For example, mRNA now is being applied not only to influenza but to RSV, and cancer vaccines. So I think we're going to see widespread applications of these new technologies. So it's a very exciting time in immunology and vaccinology.
It is amazing. And just to say it out loud, the safety of these vaccinations, I think it's remarkable. Talk to us a little bit about what you're seeing in your research.
You know, the mRNA vaccines are reactogenic. And what I mean by that, think back to your first dose. It causes a lot of immune reactivity. So people had fevers, they felt poorly, felt like they, quote, had the flu for half a day to a day. But there's a subset of individuals who do run into problems, myocarditis, inflammation of the heart. We've seen some unusual things like the induction of allergies, particularly nut allergies. We don't really understand why that is. There's a sense that there could be a post-COVID vaccine syndrome. That's really hazy right now, but some indicators of that. But when you hear those things, like anything, you have to put it into perspective. For example, if I said to you, hey, I got something for you, Steve, that you're going to love. You're going to use this every single day. Only downside of it is you run about a 15% lifetime risk of dying or permanent disability from using it. You'd probably say no way. But what I just described to you is the automobile. And it makes the point that while there are risks to everything we do, those risks are down here. And the benefits are way above where I can indicate on the screen. And that's the important point, is the risk-benefit ratio. When that's favorable, then wisdom resides in taking that particular action, that vaccine, for example. And by the way, let me just emphasize, we have 2 mRNA vaccines approved in the U.S., and we have one that's a protein subunit vaccine, like all the other vaccines you've ever gotten in your life for the most part. So there's options for people who reacted to one and maybe wouldn't to another.
That is, I am always impressed and learn so much when we visit with you. We have plenty more to talk about this morning. But if you have any comments or questions, send them in using the methods on your screen: Facebook, YouTube, the X platform, and the Medical News Network email. And I want to read a question we got while I was out of town. Jason Cohen wrote, given that COVID has been present year-round since the pandemic started, what is the basis for thinking it's going to become seasonal if it's really a year-round disease? Dr. Cohen? Dr. Cohen, good Lord. Dr. Poland?
Well, yeah, seasonal is a human perspective and time frame, right? So when you think about it, influenza is a seasonal respiratory virus for the most part. And when is that season? It's in the cooler weather. And there's a lot of debate about why, but basically the colder weather drives people indoors. They're more congregated together. There's a greater opportunity for spread of the virus. We have not really seen that yet with COVID. If you'll notice on that chart that you showed, you have spikes and wavelets that come and go multiple times throughout the year. Will this settle down into more of a seasonal pattern? There you go. You see that even within a year time frame, you see 2-ish large waves, and then buried in there are little wavelets, as we call them. And so will it settle down eventually to a winter respiratory? Maybe. But the reason it's important as a concept is if you're young and healthy, getting a dose of vaccine once a year in the absence of an immune-evading new variant will carry you through that year. Now, if you're immunocompromised, if you're older than the age of 65, as you saw earlier this past spring, the recommendation was to have another dose of the vaccine. So right now, the way these vaccines work, if you're over 65, if you want optimal protection, we'll probably be taking 2 doses a year in order to battle those second waves and wavelets.
looking back, and this is really for both of you guys, what lessons in the past few years do you think can still apply here in 2024, and vice versa? What lessons from early in the pandemic no longer apply? Hawk?
Well, I would say, we are catching up and maybe learning what some of our Asian country neighbors have been doing for a long time, and that's wearing masks. It's always okay to wear a mask. We have good definitive proof that mask wearing does help reduce your risk of getting infected with these respiratory viruses, even if other people around you are not wearing masks. I think we've learned about ventilation and being in areas where there's good air circulation. And most important, because I deal with this every day, good hand hygiene, and continue to promote good hand hygiene as well. As far as medical information, I think the biggest lessons we learned is that, again, not really everything is black and white. We need to be transparent, and just like we've heard, risks and benefit, medicine is about risks and benefit. Whatever we're doing testing or diagnostics or therapies, we always have to be concerned about the specific patient and the risks and benefits to that patient.
So I think you just said that the rules of infection prevention control keep us safe unto this moment and every day going forward. Dr. Poland, thoughts on this question about?
Absolutely agree with Hawk about. Yeah, I absolutely agree with Hawk about this. One of the things that really happened in our society, which is a shame, just to reflect, by the way, and this by itself is perhaps a little triggering. When you look at the start of the pandemic to today, 1 out of every 269 Americans died of COVID. That is stunning. That's just stunning by any measure. And yet, and that's why I love that you say in this show, show me the science, because it's science that's going to guide you even during times of uncertainty there. So, I don't come onto the show and tell you how to vote, and you wouldn't listen to me if I did. Why would you listen to a politician tell you whether to get a vaccine or which vaccine to get, or a celebrity, or sorry for you guys, but for any kind of sports figure? I won't use the name, but right? I mean, that doesn't make any sense. And so people who didn't follow the science, even though science can be not always up to date with changes that are happening faster than we can measure them, but nonetheless, it was the best information we had. And Hawk is exactly right. If you think masks don't work, the burden is on you to prove by studies that all of the studies that have been done that show that they do work are somehow magically wrong. And you're right. And we battle this every single day. Same with vaccine misinformation. And this is costing people's lives and costing their well-being. People get COVID, and no, they're not going to die of it at this point, but they run a risk, a measurable risk of long COVID that could have been prevented. And many, many times when you talk with these people, they would give anything to go back in time and change their decision. But it's too late. With all of the information, all of the academic medical centers working so hard to get this information into the hands of people, it proved very, very difficult for a substantial minority of the American population. And that's just sad.
It is sad. And I think your point about 1 in 269 Americans lost their life to COVID, how many of those were really unnecessary deaths? And that's just stunning. How do you think we can improve our messaging around vaccine?
It's really, really difficult. I will tell you what I think the answer is. The answer is to increase the scientific literacy of the population, and that has to begin in grade school. We've got to teach the principles of science-based evidence early on, in a sense, to inoculate them against mis and disinformation. The second thing I'm going to lay on us, and that is that particularly at the political levels, at some of our nation's public health agencies, you've got to be absolutely transparent. Steve, you and Hawk have mentioned this. You have to be transparent and you have to be honest, even when you know that giving this information is going to make some people panic, you have to give them the proper information. And I have found that when you are honest and transparent with people, they will listen. They do begin to understand. Absent that, it is, putting your finger in the dike of a dam that's going to break open.
I would say that I 100% agree. And one of the challenges we've had in our country and really across the world, I think, is that we have a lot of people who have majored with a miss. And that's known as a major in Internet Scientific Studies. And the problem is the curricular content with a miss degree is pretty questionable. One of the things that we know about the scientific community is even though we make mistakes, no question about that, there is a degree of rigor that is missing on a miss degree. People with majors in Internet Scientific Studies, there is no rigor in the Internet. And as a result, people say whatever they want and sometimes are instantly believable.
It's kind of like the inverse of what I said a moment ago. If you think you have a system to discover scientific truth better than what we're currently doing, then the burden is on that individual to put that system out there for peer review. There's nothing I publish, there's nothing you guys say that isn't rigorously peer reviewed by experts in the area. It should be the other way around too. You can't stand up in a theater and yell fire because people will get hurt. And yet you can publish the most vile myths and disinformation that demonstrably hurts people. And that, that you hear some passion. That's upsetting after what we've been through.
Well, it is. And to your point, it's demonstrably it's like a monster. It's monstrous what some people will do to others for their own personal or political gain. Okay, now we can't, well, I know we have questions for Alexis, but I got to ask you two more questions before. So, who named bird flu Winston disease in cows, Dr. Paul? And where are we going to go with that?
Yeah, it got named bird flu because all of the avian influenza A viruses come from birds. That is to say, all the A family comes from birds. So it got called avian and then called bird flu. So the one that has been percolating along for a couple of decades now is H5N1. What's different and that we have not seen before is a jump from avian species into a whole variety of mammalian species. Cows, which we have not seen before. Cats are dying of H5N1 on these dairy farms. They get very, very sick, even though the cows don't get that sick. It has moved into humans. And so this is what typically happens. These sorts of changes are happening right below the radar of the public's attention, of public health agencies. They don't want to talk much about the data. And then it becomes a problem like that. And the public says, well, where were you guys all during this? So I think H5N1 is something we need to pay a lot of attention to. We need a lot of research at that human-animal interface in order to understand what's going on.
Yeah, I completely agree. I think just like Dr. Poland said, right below the surface, again, he said we've seen it in cows, we've seen it in cats. We know that this disease in humans does have approximately a 50% mortality. There was a large outbreak back in 1997. And I would like Dr. Poland to comment on this as well. What we have not seen now is that it is in our pig or our swine herds. And I think once that happens, it can be very dangerous because we know that the pigs have the cellular receptors, and this is part of the Show Me the Science, the cellular receptors in their trachea where you can get a mixing of a human influenza virus with this avian influenza virus, and you don't know what can come out with that. Right now, humans really don't look to have the receptors in the same preponderance as, say, birds or the cats at this point, getting down to the basic science level. But what the concern is if it gets into our pig herds, what will happen then? Will it become more of a problem for humans?
So, Hawk, you're exactly right. Thank you for bringing that up. You put your finger right on the crux of the issue, and it is those receptors. We think of the pig as the mixing vessel between human and avian influenza viruses. And fortunately, at least in the U.S., when you are doing dairy farming, you're tending to not have pigs on that same farm. They tend to be separate entities. The problem is the birds move around everywhere, particularly along the flyways. So you're right that a lot of research at the agricultural level, so this isn't physicians, this is USDA, these are veterinarians, et cetera. Actually, I think it's at University of Kansas Veterinary School. You've got a BSL-3 veterinary facility there, and they're going to do some really important research on how this virus is spreading among cows. So stay tuned on that.
It's a big deal. And before we get in trouble in the statewide media, it's K-State University. The Wildcats have this amazing school of
Thank you. That's a Minnesota boy. It's a Minnesota boy saying
it's
it.
okay.
Completely all right.
It's okay. Although I think the people at Mankato State would be mad if you. I'm just kidding, of course. But K-State, they do a great job. So, all right. Alexis Del Cid is watching for questions from our community. Alexis.
Yen Liang wants to know, do we have to worry about testing positive for the second time this winter?
Testing positive for COVID?
COVID, I assume he's talking about, yeah.
If this past winter, if you tested positive twice, I maybe not understand the context of the question, but
I think he's still considering now winter, even though we're into spring, because we do have some international viewers, so maybe it's a seasonal change.
Again, what I would say is, again, the pandemic for the most part, for most people, day to day is not affecting you. There are populations who are at higher risk, those who are immune suppressed, those with cancer, those with other comorbidities. It's always good to have a plan with your primary doctor, what to do if you have symptoms. Test early. You may have to test a couple times if you're testing at home, and understand, can you get on that antiviral medication to help reduce your chance of hospitalization and severe disease. So I think it's really case by case. Understand and talk with your primary provider, and always have a plan.
The one thing I would kind of add to that is, every time you get COVID, you run the risk of developing long COVID. In other words, prior episodes of COVID do not protect you against the development of long COVID. That's one point. The second point, and this is really early emerging science, but every time you get COVID, including mild COVID, there are evidences of subtle brain injury and end organ injury. Even mild COVID in both the Norwegian and the English studies showed a decrement in certain elements of IQ testing of 2 to 3 points. Now, you don't detect that, you can't feel that, but that doesn't mean it isn't real and isn't happening. So again, an area of science that we have to stay tuned and develop more information about.
Yeah, that's a great point. And once again, an argument for, especially for me with a little bit of a borderline intelligence.
Right. I definitely don't need COVID.
I don't need to lose any. I don't want to lose any. I'm 64 and a half. No more losses. Alexis.
Sean has a question. Sean wants to know, when should adults under 60 get their next COVID vaccination? And when should adults over 60 get their next COVID vaccination?
Well, Dr. Poland, it kind of depends on how healthy you are baseline.
Yeah, it really does. It's both age-based and health-based, and CDC always releases that information. So the recommendation this spring was that people over the age of 65 get another booster. So I got 2 doses this year. What will happen next for your, let's just say, Alexa, for you, for example, young, healthy person, you won't get your next dose of vaccine until this early fall, and it'll be a JN1 variant vaccine.
Dr. Poland, I love that you called me young. Thank you for that. Ruth Ellen has a comment. Ruth says, I'm glad you mentioned masks. Still see people wearing those on occasion. And then Stu has a question for Dr. Poland. He wants to know, is it true Dr. Poland will soon become Pastor Poland?
I mentioned that, Phil. As a matter of fact, yesterday I passed my ordination exam, 3.5 hours of grilling. And so sometime in June, I will be formally ordained as a Presbyterian minister.
Congratulations.
Oh, congratulations. That's awesome.
Thank you.
That's fantastic.
Thank you. It's a great privilege.
Smart people do a lot of these kind of smart, and that's just that's a pretty cool deal. You know, I was born and raised a Presbyterian. I probably fell off the beaten path, but maybe knowing you, I'll get back there.
That'd be wonderful.
Our comments are turning into a love fest for Dr. Poland. So Hawkins, Stites, Dr. Stites, don't get jealous here. But Kay writes, I tuned in late. I'm going to listen to this whole program. I love it when you have Dr. Poland as a guest. I appreciate you all so much. Janet,
you know what they need to realize is that all the work for this gets done there by Dr. Stites, Hawk, and their team. So they deserve the credit here.
But let's just be honest. The people who deserve the credit are Alexis, Jill, Logan, Cliff, Maggie. I just got to keep on going down the list. Stu. I mean, these are the people who are doing all the work, and the rest of us sit up here and look cute. Well, at least he looks cute. I happen to just look.
We love when you butter us up. Flattery will get you everywhere, Dr. Stites.
Right. Well, when it's true that it's not even flattery, it's just compliment.
But we think you are pretty spectacular yourself. So Janet has a question. She wants to know, what about the doctors that say the COVID vaccines are unsafe? People don't know who to believe. It's this division, even with the CDC changing their stance, that causes people not to vaccinate. That's from Janet. What's your response to that?
Alexa, I have such sympathy with that. Kay, I think you said her name was Kay. Kay, you are right about this. And that's why I talk so passionately about transparency and truth. For example, what can happen is a good doctor could see the 1 in 10 million awful thing that happens after a vaccine, and that colors his or her outlook, not realizing that, tens of millions of people are benefiting, even though one person might have been injured by a vaccine. And we can't always predict who that would be. That's why I talk about the risk and the benefit. Here's what I personally would do in her situation. Look to your academic medical centers in your state. They have uniformly given good advice, coherent advice, and consistent advice across the nation. They are the people who are not on the front lines, but right behind the front lines, informing what the front lines should be doing. They're the ones doing the research. They're the ones putting their reputation on the line in terms of high quality science. And that's what this program has served to do. And it's why every time Dr. Stites emails me, the answer is always yes, because of the quality of this show.
You're very kind. Can I just say, I think the key is to just be honest, right?
Yeah.
You've heard us say all the time, we were building this airplane while we flew it. The truth is, we're flying a lot better. We're not a rocket ship, but we do try to tell the whole truth and nothing but the truth. And with Dr. Poland here now, so help us God.
Now I've taken a vow for that.
Yeah. So, we really do believe in it, and that's why I say you really do have to be careful with people who have the major in internet scientific studies, because it's not real. What's real is what we try to tell you every day, because our interest is to take care of you, just as it is when you come to see us in our office. We're not going to lie to you about things. Why would we lie to you? That's a terrible thing.
Here's the heartfelt response. And Steve, I haven't talked with you about it, but I have talked with Hawk. What I'm saying to you, and what Hawk and what you would say to people, is exactly what I'm recommending to my own family. It's what I recommended to my daughter-in-law when she got pregnant and was unsure what to do, and for my grandsons. I'm not going to tell anybody anything different than what I want. It's the golden rule, right? We all grew up knowing the golden rule.
And this I say, when a patient comes into our practice and you sit and you visit with them, you don't make up stuff. Whether it's about COVID or I do cystic, I don't make up stuff about treatments for cystic fibrosis. I tell people the best I can based on the science that's out there. And the science is usually not complete. So you get the best information you can.
Right.
And what we clearly know is that 1 in 269 Americans did not need to die from COVID. They did not need to die.
Yeah.
And that is a stunning thought. And if people would just assume that we're being honest, then
it turns out you can die of ignorance.
Yes, yes you can.
Well said.
Yes you can. All right, so this device right here, this device was our first studio. And here we are now, broadcasting like we are actually knowing what we're doing, because what a tremendous team of people we've had that have put this program on for 4 years. So a shout out and a thank you for people who actually know what they're doing. What I would like to do now is just ask our guests for a final thought. So I'm going to start, Dr. Poland, sir, with you. And again, thank you for the multiple appearances you've been on this program, and thanks to the folks who you work with to give you that time, allow you to have that time to do it.
Well, thank you, Steve. It's a privilege. You guys, Mayo, all of our academic medical centers throughout the nation, we're engaged together in doing the best we can for the health of the patients. And I'm going to say this deliberately this way: the patients we are privileged to care for. And that makes my point, is that I do care. We do care about your health and about your well-being and about your family and your community. And that's why we make these recommendations. As Steve said, we're not always 100% right, but we're usually right. And where there are small deficits in knowledge, they get filled in quickly, and we have the opportunity to correct those. So I would say, demand to see the science. We should give that to you transparently and clearly. That's on us. And honestly, and follow the science in terms of what should be done. Now, I know people get politically engaged with this. Did we need to close the schools for as long as we did? Probably not. But that was the precautionary principle. That was erring on the safer side. There were unintended consequences to that, particularly for younger at-risk youth, that nobody had really thought through. But that's the tension that will always be there in a public health sort of frame. So, stay tuned, watch the science. There'll be a new variant vaccine out this fall. Absolutely would encourage the use of that vaccine. Keep yourselves and your family safe.
Thank you, and I think that's so well said. Hawk?
I think we need to put the microphone and the speakerphone in Dr. Krenner's medical museum here.
Yes, I think that we will. There. That we will.
And I would just like to emphatically thank Dr. Poland. I know for me, he's been my favorite guest. I know for my parents, they loved watching him. And I know for our community and our viewers, that they have loved and appreciated the information that he has given. So thank you very much. It's been so great listening to you and helping us, Dr. Stites and myself, and helping our community as well. And I would just like to say, echoing your thoughts, we are going to continue to provide with the most up-to-date science information so that you can keep yourself safe, your family, your loved ones, and so that we can keep our community safe as well.
To all of you, I want to say thank you to all of our audience and to all the people who have tuned in, because I think it does say that you're interested in hearing what we can do with you to help inform you and to tell you the truth. And we do the best we can. And to Dr. Poland's point about students in school, sometimes we're wrong. But if you asked me to predict the Chiefs' outcome, I would be mostly right because they win a lot, but I wouldn't always be right. Unless I already knew the score, in which case I'd always be right. And that's kind of that retrospectoscope. The ability to look backwards and then tell everybody what you know, well, that's really not a talent. The talent comes from trying to believe in hope, faith, and science. I've talked about that a lot. The faith that we have in each other that allows us to work together to try and stay safe. The hope that those who are working hard at finding the answers will get there because we get there together. And finally, the science that helps keep us safe so that 1 in 269 Americans does not have to die from a preventable and treatable disease. That is, show me the science. That's what our program tries to do. Because ultimately, in the words of my favorite show, we want all of you to live long and prosper. Thanks, everyone. We'll be back soon.
How one man's skin cancer traveled to his heart. I'm Alexis Del Cid on the next All Things Heart, how that happened, the treatment, and how he's doing today.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.